Hello, everyone. Welcome to the 15th Annual Conference on the Science of Dissemination and Implementation in Health. My name is Megan Lanefall, and on behalf of the panel here, it's my pleasure to welcome you to this orientation to dissemination and implementation science. The overview of our presentation is as follows. I'll start off with an introduction and rationale for implementation science. I'll then talk a little bit about implementation frameworks, which are some of the important tools that we use in implementation science. I'll next be followed by Dr. Kara Lewis, who will talk to us about implementation determinants, Dr. Byron Powell, who will talk about implementation strategies, Dr. Kara Lewis once more to talk about methods and designs for evaluating implementation, and finally we'll finish up with Dr. Renad Baitis, who will talk about an example study. All right, so I have the weighty task of introducing you to implementation science and talking a little bit about the rationale for the field. So if we step back a bit and we say, what gets in the way of our reaching the goals that we want for public health, for well-being? What are the things that sort of present challenges or get in the way? We can think about issues with access, and increasingly we're focused on equity and thinking about whether everyone in society is able to get to the types of resources that they need. We can think about knowledge and whether there are gaps in our understanding of science, medicine, public health, or social services that help us get closer to where we want to be. But often it's that we know what to do and we don't really do it. And that's where implementation science really shines. So as we think about public health writ large, there are a number of what we would call evidence-based interventions that we know work. At a mechanistic level, we know that they're efficacious, but we still don't use them as much as we ought to in the groups that are supposed to get them. So whether that's cognitive behavioral therapy, whether that's environmental greening, whether that's vaccination in appropriate circumstances, there are many evidence-based interventions that are underutilized. On the other hand, there are things that we know we ought not to do, and we continue to do. That's where de-implementation is. But in general, when we're trying to change behavior in service of improving health, that's where we're talking about implementation science. So if you want the classic definition, go to the flagship journal, Implementation Science, go to the very first edition, the very first issue, and you will find this definition from Eccles and Mittman. So implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. This is our North Star as implementation scientists as we do the work that we do. This is what we have in mind. Many of us, especially those of us who are part of this conference, are thinking about ways to improve health, and specifically through the uptake and use of evidence that is trusted. There's another definition I want to share with you, and that actually comes from Anne Sales, who's I think of as one of the godparents of implementation science. So first, Dr. Sales defines implementation as a process of planned human behavior change under organizational constraints. She then goes on to define implementation science in health as applying the study of implementation and related processes to healthcare services, and possibly secondarily to health behavior. And what I really love about this definition is that it highlights a number of key important considerations in the field. One is that we're thinking about behavior change happening within organizations. So what that tells you is that we're interested in how we change individual behavior. So all of the lessons from psychology, from sociology, they all apply. But we're also thinking about organizational constraints, which means that we're thinking about org theory, we're thinking about management theory. And so we have to think about how organizations function and how individuals and organizations function together to really think about how to achieve change. Another piece of this definition that I love is that it focuses on healthcare services. And so as we're thinking about implementation science in health, you'll find that many of the tools and the strategies that we use are focused on the folks that actually deliver the services. So whether it's clinicians, whether it's people who are providing services, it could be social workers, it could be educators, we are thinking about people who are doing work in service of others. And that's where you'll find the most easy application of the concept from implementation science. Increasingly, people are trying to apply implementation science concepts to changing patient behavior, and that is an important area in the field, but you'll find that sometimes it's a little more difficult to apply some of the classic theories, models, and frameworks because the concepts that govern patient behavior and patient behavior change or client behavior change are sometimes different than those that govern behavior change in people that are providing services to those folks. Now, I told you what implementation science is, but where does it live with respect to all the other kinds of research that we do? So if you look at the translational research spectrum, often we conceptualize translational research as going from T0. Here, the University of Colorado at Denver calls it T0.5, but some very low number, T0, all the way up to T4, where we're starting off thinking about what a lot of folks would call pure research or basic scientific discovery, trying to understand how concepts work at a mechanistic level, going all the way up to the translation to the population. Implementation science is on this spectrum, and it's at the later end of the translational spectrum. So many of us think of implementation science as falling into the T3 and T4 end of the translational spectrum, where we're trying to think about how to translate knowledge into practice and finally to populations and thinking about public health and population health. I love talking with my basic science colleagues about implementation science because it kind of blows their mind a little bit, but I tell them none of the discoveries that they find, none of the innovations that they create will actually improve health unless there are folks that are focused on that later end of the translational spectrum. So there's room for all of us in the pool, so to speak. We all have an important role to play. But implementation science, I think of as that sort of last mile delivery of evidence-based interventions into practice. So we're squarely focused on that end of the translational spectrum. So many of us teach implementation science to folks that are interested in the field, and one of the questions that we'll get commonly is my thing implementation science? So when I say thing, I'm invoking some of the language from Jeff Curran, who's at the University of Arkansas Medical Sciences, and I had the pleasure of working on this project with him and Renad Betis, who you'll hear from later. And really what we were trying to help people understand is where implementation science fits, again, on this spectrum of discovery to translation into practice. So this is another way to conceptualize that concept. What you're looking at here is what we call the implementation science subway. And so the way the subway works is that we ask people to identify a practice of interest. So this is an evidence-based practice. It could be a guideline. It's some thing, some intervention, some innovation that you want to get into practice, that you want people to do. And once you've identified that practice, you want to ask yourself, has that practice of interest shown efficacy? Does it work? At a mechanistic level, does it do the thing that you want it to do? If you don't know that, you should figure that out. And that's efficacy research. Now, you can do efficacy research while thinking about implementation, and we encourage people to think about implementation because you don't want to come up with an innovation that isn't implementable. So I'm a clinician when I'm not an implementation scientist. And if you create a drug that requires a patient to take 6 times per day, I'm not going to use it. I'm not going to prescribe it, right? It won't work. It's not implementable. So there is a role for thinking about implementation as you're doing efficacy research. But efficacy research is really focused on, does it work? The next question, so if it does, if it actually has shown efficacy, then you want to ask yourself, has it shown effectiveness? So we're moving out of that tightly controlled, potentially randomized controlled trial into something that looks like the real world. And we're asking ourselves, has it shown effectiveness? Does it work in the real world? If you don't know that, then you may want to do an effectiveness trial. And we historically see many different effectiveness trials. Pragmatic trials, quasi-experimental or randomized trials that are focused, again, on that mechanistic question, but sort of seeing that mechanism play out in the real world. Increasingly, however, we're seeing people combine effectiveness and implementation research and ask at the same time, does it work in the real world? And how do we get people to do it in the real world? And that's where you end up in that middle prong there. Finally, if you know that it works, if no one questions that it works, you just need to get people to do it. That's where you fall into the yes category and you're squarely in the realm of implementation science. So then you're doing studies to try to understand context. You're designing implementation strategies to get people to do what it is that you want them to do. And then you're testing implementation strategies against each other to see which ones are most effective. Now, as I've alluded to, implementation science involves a lot of different disciplines. We're thinking about individual behavior change, we're thinking about organizational behavior change, and honestly, implementation science I think of lovingly as a mutt. It draws from many different disciplines. So some of the disciplines that come to mind when I think about implementation science are program evaluation, which is a strong tradition in public health, psychology, I'd put sociology in there as well, anthropology probably, community-based research, management science. Increasingly, however, we're seeing additional disciplines come to the fore as we think about implementation science. I would put systems engineering and human factors engineering in there as we think about challenges to the implementation of highly technical interventions, and behavioral economics, which is another way of thinking about behavior change that leverages the way that the human mind works and leverages the way that we make decisions. So now that we've covered an introduction to implementation science and a rationale for implementation science, namely that we're trying to get people to take up evidence-based practices, I want to introduce you briefly to implementation frameworks, which are important tools that we use in the execution of implementation science work. So theories, models, and frameworks are really the sine qua non of implementation science. You can't really do implementation science without engaging with some of these concepts. For the purposes of this introduction, I will use theories, models, and frameworks interchangeably, although semantically speaking, of course, they are different. For those of you that have had any introduction to implementation science at all, some of these concepts, some of these frameworks will look familiar. So whether it's the COMBI framework, which stands for Capability, Opportunity, Motivation, and Behavior, PRISM, REAIM, Precede, Proceed, these are all tools that we use to try to understand the context in which we're trying to change behavior and understand how we might reliably change behavior toward what we're trying to get people to do. Frameworks, theories, and models are important in implementation science for a few different reasons. One is that they represent a common language for us to talk about the science of behavior change. As we think about applying these concepts in many different disciplines, I'll give you an example. I'm an intensive care physician. So the work that I do in an intensive care unit is very different than the work that a primary care provider might do in the community, which might be very different than what a social worker might do, which might be very different than what a teacher might do in a public school. In order for us to have a common language to talk to each other about what applies across settings and what doesn't apply across settings, we need these definitions, we need these tools to help us have that conversation. And so theories, models, and frameworks serve that purpose. They also guide the process of research by structuring design and measurement and helping us introduce rigor into the work that we do. They allow cross-comparison across settings. They help us with operationalizing theory. And so there are concepts that are sometimes very abstract. We can translate those into models that apply directly to the work that we're doing, which helps us make it more concrete, more usable. And finally, frameworks, theories, and models help make sure that we consider important constructs like equity. And as I mentioned earlier, we're increasingly considering equity in implementation science and making sure that we're not recreating evidence to practice gaps or potentially worsening disparities in access, care, and outcomes. But the way that we do that is by explicitly considering equity. I would encourage you to think about frameworks, theories, and models as tools. So much in the same way that if you went to a home improvement store, you wouldn't buy every tool in the store, I hope. You're not going to use every theory, model, and framework. You'll probably have a few that are your tried and true that you'll apply in certain situations. So there are determinant frameworks, there are process frameworks, there are evaluation frameworks, and for the most part, you'll have a small number of the more than 100 frameworks that are out there that you'll end up going back to. But it's less important to anchor on which tool you're using than to think about what it is you need the tool to do and whether it's serving your purpose. I will share with you a thought from statistician George E.P. Box that Renad Baitis talks about a lot. And George Bach said that all models are wrong, but some models are useful. And this is a really important caveat to consider. These frameworks, theories, and models are not gospel. They're not perfect, but they do help structure our thinking. They do help us have a conversation across disciplines, across settings, and so they're extraordinarily useful tools. If you only have time to read one paper on implementation science frameworks, this is the one I would go to by Per Nilsson. It's called, quite openly, Making Sense of Implementation Theories, Models, and Frameworks. It offers a taxonomy of these frameworks and helps you understand when you might use one versus the other, and hopefully helps demystify them a little bit and make them a little bit more approachable. So let's say you want to use a framework, theory, or model. Where do you start? How do you choose that tool? There are several really strong resources online. I particularly like this one from the University of Washington. So what this group has done is curate a number of references relevant to theories, models, and frameworks. They acknowledge that there are a lot of them. They acknowledge the complexity of picking one, but they do make this whole concept more approachable. And so I'd encourage you to start here. You'll find some of the seminal papers in the space, and you'll find links to online utilities that can help you with selection of frameworks, theories, and models relevant to your particular implementation science question. Now with that, I'm going to turn you over to Dr. Kara Lewis, who's going to tell you about implementation determinants, and keep an eye out for some frameworks in her talk.
My name is Kara Lewis, and I am going to talk to you about determinants. I'd like to start this section by acknowledging that our field is often criticized for its excessive jargon. Determinants is a key term, though, in our field as it captures the host of factors that might prevent or enable practice improvements. These are often referred to as barriers and facilitators. And our field spent the first decade of its formalized life characterizing determinants of practice, essentially answering the questions, what went wrong, or what got in the way? The thousands of published studies on determinants of practice illustrate several key considerations when embarking on this early task in a new implementation initiative. First, determinants are multi-level in nature. Although we're often asking a single individual or team to do something new or different, we see that relevant determinants might need to be addressed at the patient, provider, team, clinic, organization, community, and system levels. Another way that scholars have conceptualized levels of determinants focuses on intrapersonal, interpersonal, organizational, multi-sectoral, political, and financial. Second, a key consideration is that there are determinants specific to the innovation itself. For instance, evidence-based practices packaged as health information technologies often have EHR interoperability as a determinant. Psychosocial interventions have skill as a determinant. Screening practices often have workflow as a determinant. And a third consideration, if we center equity in all that we do, we see that there are critical equity-related determinants across all of these levels. For instance, individual social risks like transportation and food insecurity could undermine a patient's ability to benefit from an evidence-based practice. Or under-resourced settings might not be able to deploy certain implementation strategies like practice facilitation. Given the inherent import of determinants to the success of an implementation initiative, we often start by surfacing those specific to the local context. Implementation scholars offer us a variety of methods for identifying determinants, and these include formal evidence review that leverage the learnings of past implementation teams, informal consultation when time is of the essence, quantitative surveys to systematically capture key determinants that might feature in an evaluation or analytic model, qualitative methods like interviews, focus groups, and ethnographic approaches when we seek to honor the lived experiences of stakeholders, and commonly mixed methods approaches that strategically integrate quantitative and qualitative methods. Across these methods, there are several difficult decisions to make that are driven by the purpose of your initiative. One key issue that I want to raise is that determinants are often assessed at the beginning of an implementation initiative, in the pre-implementation phase, to inform implementation, strategy, selection, and operationalization. This makes sense as a needs assessment of sorts. However, I wanted to acknowledge that there are likely unique emergent determinants that surface only once stakeholders have attempted to implement the new practice. Because determinant identification methods can be quite burdensome on the community, this timing of assessment becomes really important to think about carefully up front. There are several resources available to help you embark on any of these such methods, and I'm just featuring one here that you can find on the Society for Implementation Research Collaboration website that helps you select among the various survey instruments that might be available. One of the benefits of having a science of dissemination is that our field has produced determinant frameworks that can help us narrow in on key factors that might influence implementation in a given context. As Megan noted, there are many frameworks from which to choose. There's a useful tool at dissemination-implementation.org that can help you choose which framework might be best for you and your initiative. Echoing another comment that Megan made is that none of these frameworks are perfect, and we hope that you'll contribute to the determinant framework iteration as you embark on your own implementation research. So here you see a snapshot of the Consolidated Framework for Implementation Research. Here is a snapshot from the Theoretical Domains Framework, and here is a snapshot from the EPIS model, or Exploration, Preparation, Implementation, and Sustainment. Finally, as the multinational tailored implementation for chronic disease study showed, more determinants emerge than can likely be feasibly addressed in a given initiative. In fact, the TICD that I mention here surfaced 601 plausible unique determinants across levels of influence. So, methods for prioritizing determinants are sorely needed. And there are several methods available. And across these, we see stakeholder engagement, but different processes and different parameters. It's an empirical question about which parameters are best to help this prioritization process. I've put up on the screen for you importance and feasibility, as they are often evoked in this determinant prioritization process. It allows teams to tackle determinants that are perceived as of most import and are most feasible to address. In our implementation science centers, we're testing other parameters that might be useful to implementation initiatives, and these include chronicity, criticality, and ubiquity. Regardless of what parameters you choose in this process, though, we must remember that determinants are more than likely interdependent and not simply discrete factors operating in isolation. Thus, our field could do well to articulate a theory of the problem to characterize the interrelationships of determinants of practice. And on that nerdy note, I will hand it over to Dr. Byron Powell.
Hi, my name is Byron Powell, and I'm Associate Professor at Washington University in St. Louis, where I co-direct the Center for Mental Health Services Research and serve as Associate Director of the Center for Dissemination and Implementation. And it's a pleasure to share a bit about implementation strategies today. So to start off with, implementation strategies can be defined as methods or techniques used to enhance the adoption, implementation, sustainment, and scale-up of a program or practice. And implementation strategies can vary a lot in terms of their complexity. So sometimes you'll see mention of discrete strategies or single component strategies, which involve a single action or process. So some examples of this could be clinical reminders, audit and feedback, or clinical supervision. More often than not in implementation, you'll see examples of multifaceted implementation strategies or implementation interventions that combine multiple discrete strategies. There are a number of tools that can help you to identify and describe your implementation strategies, hopefully in ways that are consistent with the prevailing literature. And these tools are not meant to be or are not completely comprehensive and should in no way constrain your creativity, but may be helpful nonetheless. One of those examples is the Expert Recommendations for Implementing Change compilation, or ERIC compilation, which lists 73 discrete implementation strategies in these 9 broad categories that you see here on the slide. And the full compilation can be seen in that Powell et al. 2015 reference below. And I'll also note that the sort of the most comprehensive version of those definitions is found in additional file 6 of that publication. You may have seen other compilations of intervention techniques. So two common ones are the behavior change methods associated with intervention mapping or the implementation mapping approach. That's seen here on your left. And then a very common one is the behavior change technique taxonomy developed by Susan Mickey and colleagues. That's been used widely in behavior change, intervention development, and implementation science as well. We actually think that the behavior change technique taxonomy can be quite complementary with the expert recommendations for implementing change compilation on the previous slide. And Sheena McHugh from University College Cork has recently published this paper describing the ways in which using both compilations could actually improve the reporting and description of implementation strategies so that the strategies that we use could be operationalized better and more easily replicable in research and practice. There's a growing body of evidence for implementation strategies, and I certainly won't go over all of these, but these are just common examples that are represented in the Cochrane Effective Practice and Organization of Care group's repository of systematic reviews and meta-analyses for implementation strategies. And so I note these here, and also note another potential source for identifying evidence for implementation strategies, which is healthsystemsevidence.org, which is run out of McMaster and is a great resource for identifying systematic reviews and meta-analyses that have actually been graded according to their quality. One of the challenges, despite this growing evidence base, is that oftentimes implementation strategies are not necessarily well matched to the types of challenges that we're facing in practice. Michelle Vensing and Richard Grohl have noted there's often little association between the type of problem and the approach taken to change, and more particularly that organizational and system-related problems tend to be ignored, even when those are detected, favoring individual educational and psychological approaches. So there appears often to be a mismatch between the types of strategies that we're using and the types of problems that we're facing. And so we've suggested a number of ways in which we could enhance the impact of implementation strategies over time. And I'm going to emphasize 3 in particular today, which are enhancing methods for designing and tailoring implementation strategies, specifying and testing mechanisms of change, and improving tracking and reporting of implementation strategies. French and colleagues have outlined 4 basic steps for developing theory-informed implementation strategies. And there are a number of methods that are emerging to make this process more systematic. But I think that these 4 steps cut across many of those methods that we might consider. The first is to identify who needs to do what differently in order for implementation or sustainment to be improved. The second is to use theory and frameworks to identify determinants or barriers and facilitators to those types of changes. And this was represented very well by Dr. Lewis, who outlined multi-level barriers to change, and as well as a number of methods to assess potential determinants. So thinking about informal consultation, literature review, formal qualitative, quantitative, or mixed methods, approaches to identifying determinants. We next want to select implementation strategies that are likely to be effective, acceptable, and feasible to a variety of stakeholders. And then finally, deciding how that change can be feasibly and robustly measured. Including factors along the hypothesized causal pathway, as well as any implementation outcomes that might be pertinent to measure. And I think it's important to consider equity at each of these steps and explicitly integrate those considerations. And Larissa Gaius has an excellent paper that I think maps very well to the previous slide. And she sort of takes you through the process of developing or adapting an implementation strategy. And there are a number of pertinent questions that are outlined here that will help us to more explicitly center equity throughout the process. Ultimately, when we do that, we would like to see tight links between the types of determinants that we're addressing, the strategies we're using, the mechanisms through which those are working, and the outcomes that we're ultimately hoping to achieve. So just to give one example here, if we have a provider skill deficit, it may be that training or teaching in practice with corrective feedback is an effective implementation strategy that hopefully would operate through the mechanism of skill acquisition, refinement, and mastery to improve fidelity to an evidence-based practice. There are a number of other examples here on the slide, but the idea again is that rather than sort of having this mismatch between our strategies and the types of determinants we're addressing and the outcomes we're achieving, hopefully these things would be well aligned. And obviously when this is put in a multifaceted strategy context or multi-level strategy context, we'd like to make sure that our strategies are working together synergistically, that they are put together in such a way that we're sensibly addressing multi-level barriers to change, and that the component strategies that are part of our multifaceted strategy or implementation intervention are working together well. This is a nice example from Dr. Sam Schilling at the University of North Carolina, who's a child abuse pediatrician and has an intervention called PriCare, which is a primary care-based intervention to prevent child maltreatment. And here in this paper, she shows not only how these various implementation strategies fit together in a synergistic way, but also provides a really nice background of their empirical and theoretical justification, and shows how she's evaluating their use in this package. So would urge you to take a look at that paper for more detail. Increasingly, the notion of implementation mechanisms has been prioritized in the field of implementation science, and this is certainly true from the National Institutes of Health, who have identified the identification of possible mediators, moderators, and mechanisms of action that explain the impact of dissemination or implementation strategies on relevant outcomes as a priority. And there are a number of ways in which understanding mechanisms can help us advance the field. First, it would really help us through this previous process of systematically designing and tailoring implementation strategies. Again, if we understand how the strategies that we're using are effectively addressing determinants and how they're sort of linked to our ultimate outcomes of interest, that would certainly help the process of designing and tailoring. It would similarly help us to adapt implementation strategies that are developed in one setting to another, knowing what elements need to be adapted, what elements need to be maintained in order to ensure the effectiveness of those implementation strategies. Similarly, it would help us to understand generalizability and the role of context in implementation science, and I'll give an illustration of that on a subsequent slide here. And then finally, it would help us to replicate positive findings, and I think very importantly, would help us to learn from negative studies or null findings in the field. So one example of that is this paper led by Elvin Gang, who was taking a look at a study that represented null findings in the field on knowledge brokering, and was just making the case that really understanding this strategy, knowledge brokering, on the ultimate outcome of interest, which was evidence-based staffing in a hospital setting, we really need to understand the mechanisms through which that strategy works. And doing so would also sharpen our focus on contextual elements that are important. So for instance, knowledge brokers are intended to work through cultivating a social link or relational development with, in this case, hospital managers, by providing them brokered knowledge that is packaged, simplified, contextualized, so that they can absorb that knowledge and integrate that into their practice, ultimately, hopefully, leading to evidence-based staffing. It also works to facilitate individual and organizational capacity for change, and the manager's ability to actually use and interpret that data. And certainly contextual elements will influence the effectiveness of that implementation strategy. So in this case, the knowledge broker's status within the organization will influence their ability to cultivate a social link, or that relational development piece. And so specifying these mechanisms of change, I think, actually sharpens our focus on certain contextual elements that we might want to measure or assess quantitatively, qualitatively, or through mixed methods. And I think that's important, particularly because in the field of implementation science, we often can get sort of overwhelmed with a list of contextual elements or barriers and facilitators that is long and difficult to prioritize, as Dr. Lewis emphasized in her talk. We have a number of studies ongoing that are focusing on understanding mechanisms, and just want to highlight two here that are led by Dr. Lewis. One is funded through an AHRQ R13 conference series, which is recently wrapped up and focuses on developing a research agenda for understanding mechanisms in implementation science. And the second is an NCI-funded R01, where we're learning a lot from funded investigators who are looking at mechanisms in their studies, and sort of how these investigators are thinking about that. We're also developing causal pathway diagrams for 30 commonly used implementation strategies, developing measures for commonly used mechanisms in the field, and developing ultimately a database to house that emerging science. And finally, one of the major challenges in the field is how we actually report implementation strategies, and that's poor reporting in the field has really limited replication in science and practice, and precluded answers to how and why strategies work, or understanding mechanisms, as I was emphasizing previously. And that's because we often don't really know how investigators got from point A to point B. We don't know what strategies they used, how they used them, and if we wanted to replicate them, we often couldn't do so. So we've suggested in this paper led by Enola Proctor, Curtis McMillan, and I, we've suggested some guidelines for specifying implementation strategies. First, encouraging folks to name the strategies in ways that are consistent with the prevailing literature, to define them operationally for their context and their use, and then to specify them very carefully using these dimensions. So thinking about who are the actors, what are the specific actions that they're taking, what are the action targets, or this sort of starts to get at what are the mechanisms through which this works. Is there anything about the timing or sequencing or dose of the implementation strategy that is important to report? Ultimately, what is the intended implementation outcome or other intermediate outcome that you're attempting to address? And then, I think importantly, what is the empirical, theoretical, or pragmatic justification for the inclusion of each component strategy? And each discrete or component strategy could be specified using these guidelines. So if you're using a multifaceted strategy, or for instance something like a learning collaborative, you might specify each element of the learning collaborative according to these dimensions. So even if we document implementation strategies carefully initially, based on a well thought out implementation plan, and we describe them even according to the guidance on the previous slide, we know that implementation challenges will emerge, and that modifications to these strategies may be necessary. So we urge folks to carefully track implementation strategies, as we monitor barriers and solutions, to describe any modifications to the plan strategies, and to identify and describe any additional implementation strategies as the process unfolds. And there are a number of methods for tracking implementation strategies, but also I think a lot of room for methodological development here to develop more pragmatic and useful ways of doing this. But I urge you to take a look at the references below, and I will conclude here and turn it over to Dr. Lewis to talk about designs and methods for evaluating implementation strategies, but thank you so much for your time.
I'm Kara Lewis, and I'm going to be talking to you next about methods and designs for evaluating implementation. When it comes to evaluating implementation initiatives, we must remind ourselves, what do we really care about? I would imagine most of you would answer that we care about improving individual, policy, and population health outcomes equitably. To get us there, our starting place is the evidence-based intervention, policy, practice, package, what have you, because it has the evidence of impact. And we do the hard work now of bringing that evidence-based intervention to those who could benefit. One pathway is that of dissemination, which has its own outcomes, and the other pathway is implementation, which also has separate outcomes. However, leaders in the dissemination space argue that instead of D&I, we should be thinking of D2I. And if you're interested in hearing more about that, I encourage you to read the excellent chapter by Jonathan Pirtle and colleagues in the new textbook called Practical Implementation Science. We are so very fortunate to have the seminal paper by Enola Proctor and colleagues published in 2011, which importantly differentiated implementation outcomes from service outcomes and patient outcomes that depicts them as cascading in their influence once empirically supported treatments are integrated via implementation strategies. Like determinant frameworks, there are many evaluation frameworks from which to choose. The good news here is that there's significant synergy, comparability, and overlap across these. On the screen are but a few for you to consider. REAIM appeared on the scene first in 1999 and includes a mix of effectiveness and implementation outcomes, which is ripe for hybrid trials. Next appeared Proctor and colleagues' framework that I showed you previously that similarly covers a lot of ground. As a third example, we have the new Consolidated Framework for Implementation Research Outcomes Addendum, which importantly centers equitable population impact. There are 3 papers captured on the screen for you that offer different types of support. So in the upper left-hand corner, this paper will offer you conceptual information about implementation outcomes and how that can inform measurement and evaluation. Then on the upper right-hand part of your screen, you'll find a paper that offers psychometric information about quantitative measures of implementation outcomes to help you choose among those that might be best for your initiative. And then third at the bottom, you'll find 3 relatively new brief measures of implementation outcomes, specifically for acceptability, feasibility, and appropriateness, which are available now in almost 20 languages. As another measurement resource to support your evaluation efforts, look to the forthcoming 3rd edition of this book, where you will see an updated table like the one on the screen. In this updated table, not only will you find information about the level of analysis of your outcome of interest, the theoretical basis for it, synonyms, salience by implementation phase, the nature of the outcome, be it manifest or latent variable, and example measurement methods, but also we offer equity considerations in the 3rd edition of this chapter. Similarly, you will find an excellent resource by Rachel Shelton and colleagues in which they published an extension of REAIM in May 2020 to address the dynamic context and promote health equity over time. In their article, they pose questions for each REAIM outcome that are motivated by health equity consideration, and I included some of those on the screen here for you to see. As Byron so eloquently articulated, when evaluating implementation strategies, it is important to settle on outcomes that hold promise of being achieved given the link between the determinant, the strategy, and the outcome. And a different way to approach conceptualizing the impact of implementation strategies is by developing some sort of causal diagram. This is but one of many graphical depictions, and the interesting thing about this particular approach is that the nuance demanded in articulating proximal and intermediate outcomes offers signals that a strategy is exerting its intended effect. Too often we see teams waiting months and years to learn that progress in achieving implementation outcomes is suboptimal, And so we encourage teams to articulate early observable signals that the strategy is working through the hypothesized causal pathway. So looking for things earlier than implementation outcomes such as fidelity or sustainment. And here's an example of clinical decision support embedded in the EHR as an implementation strategy on the left, striving for increased depression screening rates, a distal implementation outcome all the way on the right. This pathway unpacked illustrates that an early signal of success would be that individual clinicians are administering a depression measure like the PHQ-9, showing us that the strategy is holding promise for its intended ultimate outcomes. As mentioned earlier, qualitative and mixed methods are widely used in implementation and often in the evaluation of the initiative itself. For the latter, mixed methods, integration is key. And on the screen are several field-specific as well as more general resources to help you consider when to use each of these methods. Implementation evaluation demands a host of designs that honor the values of our stakeholders, limit the burden on the practice community, acknowledge that the unit of analysis is often the clinic, the hospital, or even the community. And moreover, we need designs that allow us to fail faster so that we don't subject our stakeholders to a 5-year trial that yields nil results. Here on the screen are a couple of excellent resources to help you think about study designs appropriate for implementation evaluation. And hybrid designs are an example of something useful when trying to learn about both effectiveness and implementation, with different versions of these hybrid designs offering to tip the balance in either direction, either in the direction of effectiveness or in implementation. The state of the intervention science will likely dictate which you will choose when, but there are now many examples of these in the published literature and resources associated with hybrid designs that can help you in that decision-making process. As another resource, consider this guide for designing, conducting, and reporting on implementation trials, co-authored by international leaders in this space. And there are also opportunities for innovation with respect to design. I urge you to consider this viewpoint by Drs. Guastafaro and Collins, in which they bring multi-phase optimization strategy to implementation science. They offer a framework to optimizing implementation within the contextual constraints of the intended practice context. Another area that remains unfortunately innovative is economic evaluation. Although we still need a common framework for economic evaluation to facilitate comparability, there's much we can learn from this cross-journal special collection on the topic, where you'll find several papers grappling with these issues from recent years. I will end this section by pointing out a protocol that was recently published that points toward a scoping review undertaken by Dr. Langak Hall and colleagues to characterize the conceptual, theoretical, and measurement-related advancements since the 2011 Implementation Outcomes Framework was published. I think this work will once again transform the field, and I'm excited to see where it takes us next.
I'm Rationale. I am professor and chair of medical social sciences at the Northwestern University Feinberg School of Medicine. I'll be giving you an example of all the concepts that Megan, Kara, and Byron brought to life earlier in this presentation. I'll be using the use case of pediatric firearm safety promotion. First, I want to give you a sense of the why of why we're doing this work. The rate of youth suicide is increasing in the United States. If you look at the CDC graph, you'll see on the x-axis the dates, and on the y-axis the number of deaths per 100,000 young people in the United States. And if you follow that red line, you'll see the suicide death rate in our country. From 2007 to 2016, where you see that red line above the graph, the suicide rate increased 56%, from about 4 to 6 per 100,000 youth aged 10 to 19. Importantly, firearms are responsible for half of those deaths, as firearms are among the most lethal suicide method. One in 3 homes in the United States have firearms. In fact, most homes with a firearm have multiple firearms. Only 3 in 10 families store their guns unloaded and locked with the ammunition stored separately, which is the recommended manner in which to store firearms securely, representing an important target for prevention. Even a modest increase in safe firearm storage could prevent up to 32% of firearm deaths in youth, including suicide, as evidenced by a simulation study conducted by Monito and colleagues in 2019. So when we set out to think about how we could apply implementation science methods to this particular use case, we asked ourselves, where could we reach the most youth if we wanted to intervene to increase safe firearm storage as a universal suicide prevention strategy? So whenever you are looking to reduce a care gap, you have to think about what settings you might want to be intervening in where a particular program or thing ought to be implemented. In this particular use case, we decided to start with primary care, which tends to be the first line of defense for our health systems. So when we went to the literature, we learned that, in fact, there is a principle-driven, evidence-based practice for pediatric primary care that existed called the safety check. And the safety check was tested in a large randomized controlled trial in 2008 by Sherry Barkin and colleagues, and demonstrated that delivering the safety check resulted in increased firearm storage by parents of young children. And the essential ingredients of this evidence-based practice include screening for firearms in the home, having a brief conversation around secure firearm storage, and offering free cable locks. And the focus of this particular violence prevention program was unintentional injury in young people aged 2 to 11. So our entry point into this work is after the research team had already developed an intervention with a focus on the core components. So coming back to the subway line, which Megan walked us through earlier in the presentation, I can walk you through now with this particular use case. So if you follow the green stars, you can see that we were able to identify a care gap and then a practice of interest. And that practice of interest had been tested in a large effectiveness trial previously, thus setting us up for the bottom of the subway line, the green implementation science subway line, to consider mixed method studies to understand the context and how one might go about implementing this effective program for universal suicide prevention in pediatric primary care. So the first set of work that we did in this space was very much focused on that mixed methods assessment of context and fit with the innovation. And this was work led by my colleague, Courtney Woke. So we were really interested in answering this question of what contextual factors might hinder or facilitate implementation. And some of the key things I want to highlight for you, while the content is very interesting, and I'll go through that with you, is methodologically what we tried to do was talk to any stakeholder group that would be influenced or impacted by the implementation of this program. So we selected 9 stakeholder groups after talking to colleagues and experts whom we thought would be very important to include in the process of thinking about mixed methods assessment, including parents, physicians, nurses and nurse practitioners, leaders within health systems, third-party payers, leaders of national bodies like the American Academy of Pediatrics, and firearm experts. And you'll see that in a few of these boxes, we also have in parens the number of people who were firearm owners, just so that you can get a sense of our sample. So as part of these semi-structured interviews, we use the Consolidated Framework for Implementation Research, which you heard Megan discuss earlier in the presentation, to guide the questions that we asked, as well as our coding process subsequently following the interviews. So I'm going to stay really high level and walk us through the 5 domains of the CFR and what emerged within these qualitative interviews with all of our stakeholders. So the first kind of large theme that we took away was related to the outer setting or the broader sociopolitical context. So we heard about firearm culture in the United States as a politically divisive topic that can raise concerns around Second Amendment rights and illegal ownership. For example, one behavioral health leader said, so we're talking about coming into a culture trying to do a very reasonable urban intervention on a mostly rural population that's politically very, very charged around gun rights. So again, thinking about the context in which we're implementing and how firearm culture might affect that. Interestingly, in these interviews, we learned that recent high-profile gun-related incidents were making it easier for clinicians to initiate these questions and conversations. So the outer setting was affecting or facilitating the ability to have these conversations. The inner setting refers to the unit in which one is implementing within the health system or the pediatric primary care setting. So we heard from our stakeholders the importance of the need for system buy-in and alignment with priorities. So this leader of a primary care practice said, I think the health system is really good about standardizing things and rolling it out. But at that top level, if that level is not sold on it, then nothing will happen. So really spotlighting that anything that we might be implementing must be a priority for leaders in that context. With regard to the characteristics of individuals involved, we heard a lot about the importance of having knowledge to be able to have a conversation around secure firearm storage and how cable locks are used, self-efficacy or comfort in talking about sensitive topics, and a really important need for a non-judgmental stance so that it doesn't feel like clinicians are making judgments about a parent for owning a firearm. We also asked stakeholders about who should do each component of the program, since it could be disaggregated and offered by different individuals. And remember, the three parts are screening, counseling, and offering firearm locks. And we heard that nurses or medical assistants might do the screening and the firearm locks, while it felt that it would be important for a physician or nurse practitioner to do the conversation around secure storage. We also heard a lot about the importance of intervention characteristics as they relate to the program that we were trying to implement. So pictured here are the three components of the program, and based on both quantitative and qualitative work, we heard high acceptability and feasibility around two of the components, screening and offering counseling or talking about safe storage. A lot of suggestions around using the electronic health record for screening and then offering written resources for safe storage recommendations through the electronic health record. With regard to offering cable locks, which a review suggests might be the most potent aspect of the intervention, there were some concerns about how sites would pay for those locks, store and distribute them, as well as a minority voice concerns around liability. And there were some suggestions around referring patients to get free locks in the community rather than offering them within a health system. Finally, brevity was highlighted as a critical component of any intervention that we might implement in a primary care setting. This leader of a primary care practice said it has to be something very concise, very to the point, that does not take, ideally no more than 1 minute. And for all of you all thinking about implementation, especially in primary care, time and again comes up as a major barrier to being able to do many of the things that we would like clinicians to do with their patients. Other themes that emerged, you can see again time being a crucial point here. And then facilitators include integration into the electronic health record and into other anticipatory guidance that pediatricians and pediatric primary care providers already offer. Now, you may have noted that in our stakeholder groups, we also talk to firearm experts, and this is work led by my colleague Sherry Yeagerheimen. And what was interesting about that, and I really want to push you to think about who are all the stakeholders who might be impacted by an implementation, because we would be missing something really important if we hadn't talked to this group. We learned that actually one component of the program is not as acceptable to these individuals as other stakeholders that we talk to. And the driving force behind that was a concern around individuals being put into a database within the electronic health record that at one point might become a federal registry of gun owners. We also heard about the lack of trust and concerns that a public health platform for firearm injury prevention is really a disguise for firearm control, and the need for partnership, which is so foundational to implementation science, and calls to partner with firearm safety community who are more credible messengers. And I will say my colleagues in the firearm safety community have been incredible in supporting this work and teaching us how to do it in a respectful, non-judgmental way that really represents a true partnership between health systems and firearm safety experts. And so the moral of the story from this slide is that you really need to think about all of the people who you might engage with and really understand impacts. So this mixed methods contextual inquiry work on the green line of the implementation science subway led us down two pathways at the same time. So one related to adaptation. So we did hear some feedback about the need to adapt the program, particularly for suicide prevention, and to ensure that it was highly acceptable to parents. The second bucket or pathway was preparing for a trial. So if you remember that subway line, you remember at the bottom that there are 3 stars, and this work led us to then focus on designing implementation strategies and testing them. So now I'll tell you just a little highlight about how we adapted the program while keeping the core components in mind. And this is work led by Molly Davis and Katie Hoskins. And it kind of takes us back to the beginning of the pathway as we think about how to adapt the intervention or program to make it highly acceptable and potent. So we used an established adaptation framework called Adapt It, and we iteratively adapted the program, which resulted in a new program name, tweaked content, and a new logo. I will note that we really tried to keep the core mechanisms and behavioral ingredients, thus not requiring us to go all the way back to the beginning and do a hybrid type 1 effectiveness study. So I think that's an important point to make. So what we did is we took all that qualitative feedback from our 70 stakeholders, we adapted the safety check, and then we got additional qualitative feedback from 9 suicide and firearm safety experts about those adaptations. We then crowdsourced the name and logo and got feedback from 562 parents nationally. And then we incorporated that stakeholder feedback and new name and logo into the adapted program and got quantitative ratings about acceptability and appropriateness from a new sample of 106 parents, including gun owners. And now you can see our logo and our name, which is Safe Firearm, and now it includes 2 components: a conversation about secure storage and offering cable locks. We have removed the screening component per the feedback that we heard from our stakeholders, and we offer this program to everybody, irrespective of whether or not they report having a firearm. So it's a universal approach. We also, as I mentioned, started to work on designing implementation strategies and testing them. So I'll tell you a little bit about how we designed our implementation strategies. So we used an approach called implementation mapping to derive a set of implementation strategies. And essentially what that means is that we took all of the qualitative input from our stakeholders, we looked at the literature, and then we came together as a study team and came up with a list of strategies mapped on to barriers and facilitators that we heard in the qualitative assessment. And so we used a logic model, an implementation research logic model, to list the barriers and facilitators, the implementation strategies, the mechanisms through how they work, and the implementation outcomes, bringing it all together. And these were the main strategies that we derived that mapped onto the primary themes that we heard. And again, integrating the program into the electronic health record is a great example of one of the strategies that almost every stakeholder in the health system raised. So once we had our list of implementation strategies, we then were ready for prime time to do an implementation trial. We decided to do a hybrid trial rather than a trial that would not look at effectiveness, just an implementation trial, because we adapted the program and we felt that it would be most appropriate to include effectiveness outcomes as well. So the current study that we're doing right now is in partnership with Kaiser Permanente Colorado and Henry Ford Health. And the primary question that we're hoping to answer, piggybacking off of the menu of implementation strategies derived through implementation mapping, is the less costly and scalable electronic health record-based nudge powerful enough, or is more intensive and expensive facilitation needed, which is an additional implementation strategy to overcome barriers in the case of this sensitive intervention. If you'd like to read the study protocol, it's published in Implementation Science for more details. And ultimately, this is a type 3 trial. We have 30 clinics, 151 clinicians, and about 40,000 youth. Half the clinics get just the nudge, which is essentially a change to the well-child visit template, reminding clinicians to talk about firearm safety and to offer cable locks. The other half of the clinics get the nudge plus 1 year facilitation, which is a clinic-level implementation strategy hypothesized to work through clinic-level adaptive reserve. And that's our mechanism, and we are testing that as part of the trial. Our primary implementation outcomes are reach, or the number of young people who receive the program over the number eligible, and fidelity, which is measured as parent-reported following their well-child visit. One of the really exciting aspects of this work is work that is led by Katie Hoskins, where we've been focusing on probing for signals of inequities prospectively. So she's recently published a paper where she describes how we operationalized probing for signals of inequities prospectively, including ones that we heard from our partners in the clinics, as well as hypothesized inequities based on the literature. So I'll direct you to that for more information. So in closing, I want to thank the incredible team who makes this work possible. It truly takes a village, and everybody here has been responsible for making this work a success. So thank you. The last thing I want to share with you before I finish up here today is this paper that was recently published in Implementation Science that includes all of the presenters from this orientation today. And this was a really incredible opportunity to think with our colleagues about both the promises and pitfalls in implementation science as we see them as folks who've been doing this work for some time now. And I think that there's some really actionable next steps outlined in this piece that I hope you will take a look at and enjoy reading, and we hope to hear from you and really hope that this paper elicits some discourse and conversation in the international implementation science community. So in closing, I want to thank you for taking your time to listen to us today. It was a huge honor and pleasure for us to have the opportunity to share our knowledge and reflections with you. And all of us remain available to you all and look forward to hearing from you in the future. So thank you very much.